I invite Dr. Kim Ramasamy. He will be speaking on systemic parameters and their management in diabetic retinopathy.
Good morning, and thank you, Dr. Ajit Babu, for inviting me to be a part of this event. Diabetes, we all know, is there everywhere. Every other third, fourth, fifth person is diabetic when we are walking on the road. And today, the recent IDF has shown that the number is what we used to think as 470 million is 6.7 million, 537 million is the current prevalence of diabetes globally. Recent study done by the Smart India group, many multicentric study that was done in India, has given us the idea on what is the prevalence in India. India is supposed to be the capital of the world, and today we have a huge number. I won't go into the details, but 12.5% is the prevalence of diabetic retinopathy, retinopathy in the country. Coming to the topic on systemic parameters, what are the different parameters? We all know there are so many risk factors for diabetic retinopathy. Some are non-modifiable and there are modifiable factors. Modifiable is, as we all know, hyperglycemia, hypertension, dyslipidemia, obesity. And there are various other factors which we on a regular basis do not look forward to it. But there are enough evidence in the literature to show that why these, especially hyperglycemia, hypertension, nephropathy, all these are important in diabetic retinopathy. One of the most important things is the duration of diabetes, which is significantly a risk factor. The longer the patient has diabetes, more the chances of them developing any retinopathy. The higher frequency in gender, men seem to have a much higher prevalence over the female gender in the prevalence of diabetic retinopathy. In the recent Smart India study, it was also shown. We used to think that patients in the rural areas do not have as much a higher prevalence as the urban population, but it appears that it is almost similar whether you are in the rural or in the urban population. Glycemia, as we know, is the single most significant risk factor, which has been shown repeatedly in multiple multicentric studies, which have shown the importance of glycemic control. Even the Chennai, the CURE study by the Mohans group had shown every 2% elevation of HbA1c, the risk of diabetic retinopathy increases by a factor of 1.71. So there are, as I mentioned, multiple clinical trials have shown. Again, the Mohans group has shown the importance of following these patients with good control. The aim was to assess the relationship between the regularity of follow-up and the risk of complications in patients with type 2 diabetes who were followed for a period of 9 years, and it was found that the regular follow-up was associated with significantly lower glycemic burden and lower incidence of retinopathy and nephropathy over a period of 9 years. So it is very clear that these patients, if followed regularly for their systemic factor, would definitely benefit in controlling the diabetic retinopathy. The effect of glycemic control has been shown very clearly that even if a person controls the diabetes strictly within the normal limits, the chances of them developing diabetic retinopathy is 25%, but again, the chances of developing any severe retinopathy is much, much lower. Regarding hypertension, of course, it's proven that the tight blood pressure control reduces the diabetic retinopathy progression by 34%. And the ADA has recommended that the BP levels are kept within 130 by 80, should be aimed for people, especially with diabetic retinopathy, to reduce the burden of diabetic retinopathy. Serum lipids, again, another factor which we are all aware of, where the hard exudates, which we very often see, are often associated with diabetic macular edema, and the higher levels of cholesterol, or especially triglycerides, were associated with increased risk of these diabetic macular edema. Dr. Amod Gupta and the PGI team from Chandigarh have very clearly shown the role of oral atorvastatin in patients with type 2 diabetes with dyslipidemia. So many a times we do treat these patients, especially if they have a high cholesterol or high triglycerides, treat them before you even treat them with the anti-VEGF drugs in severe macular edema. Also in diabetic nephropathy, subjects with microalbuminuria were around 2 times as likely to have diabetic retinopathy than those without microalbuminuria. And especially when they have macroalbuminuria, the risk is almost 6 times. Pregnant women are more likely to develop retinopathy and have progression. And in women who begin pregnancy with no retinopathy, the risk of developing diabetic retinopathy is about 10%. And they should be counseled regarding the effect of pregnancy on the retinopathy for the diabetic women. All pregnant women with established diabetes should be screened in their first trimester for any evidence of diabetic retinopathy. And if they have any retinopathy, like severe retinopathy, it should be treated before the patient proceeds with the pregnancy. Anemia, again, individuals with anemia were 1.8 times more likely to develop diabetic retinopathy than individuals without retinopathy. In men, the risk of developing diabetic retinopathy increased to 2 times, but not so much in women. Anemia, as we know, is an independent risk factor for the progression of diabetic retinopathy. It promotes angiogenesis and worsens diabetic retinopathy. Very often, even diabetic, if you don't look for HB and the patient is anemic, they may have a lower HbA1c level, which will falsely indicate that the patient is under good control. Another important factor is the cardiac outcomes in patients with diabetic retinopathy. This overall 12-year overall survival rate for patients who undergo CAPG is 40% for diabetics with retinopathy compared with patients without retinopathy. It's almost double, 88%. So we did a study to understand the impact of diabetic retinopathy on the cardiac outcome after coronary artery bypass. It was an 18-month outcome study, prospective observational study. We looked at the fundus at the baseline before they went in for the presence of diabetic retinopathy at the baseline. And then the patient went through the entire process. But what it clearly showed was that diabetic patients who underwent diabetic retinopathy patients who underwent CAPG had more adverse cardiac events than those without retinopathy. It was very clear. Adverse cardiac events were reported in 65% of patients with diabetic retinopathy. So it can be, especially when you're treating a patient, when the patient with CAPG is, with diabetic retinopathy is going for a CAPG, they should be more carefully followed for problems related to cardiac issues. This is from Dr. Raji Raman's group, how well in the DREAM study they've shown in the population that only 34.4% of the diabetic patients have good glycemic control, 45% with systolic blood pressure control, and 60.6% with diastolic, and only 36% had a LDL control. So it really clearly shows that we are not there, the awareness is not there, and it's very important that this should be addressed on all these patients. And how often do we as ophthalmologists or as retina specialists talk to the physicians or to the diabetologists to ensure that the patient that we are treating is under control, or how often do we regularly monitor the diabetic? Every time you see it, are we taking a HbA1c level every 3 months or every 6 months at least? It's a big question mark. Very few people follow up on those patients very systematically, because literature clearly shows that you follow these patients on a regular basis and ensure a good control of all these systemic factors, the chances of these patients losing their vision to diabetic retinopathy is much less. So it is important for ophthalmologists to follow up on these systemic factors and collaborate with their physicians. Thank you.